I'm Matthew Craig. I'm an orthopedic surgeon who specializes in sports medicine. I went to undergrad at the University of Michigan in Ann Arbor, where I grew up. After that, I went to med school out at Georgetown in Washington, D.C. I did a residency program in orthopedic surgery in Chicago, Illinois, at the University of Illinois there. Then I went out to Utah for a year to do further training in sports medicine, and then came back to the Midwest. So when I was in medical school, I went in thinking I would be a radiologist, and then I realized pretty quickly after spending time in a darker room just looking at images that I didn't really enjoy not having regular interaction with patients. I started my surgery rotation and I really enjoyed orthopedics because it offered the chance to work with a lot of younger, healthy patients and help restore them back to function and get them back to day-to-day activities or back to sports, which some other specialties didn't offer. So I did my training in Chicago where we kind of worked with multiple providers there in different settings, a little bit of rural Illinois as well as kind of the downtown population. Out in Utah, we got a chance to take care of a lot of high-level athletes, football players, Olympic athletes and things. And then now I'm out here in Ohio. I think if I look back and think, there's been multiple challenging patients I've had experience with in the past. I think a lot of the times you start to realize that it's not just their orthopedic problem that's the only problem you need to address. There are a lot of family issues, social issues, difficulties with insurance, difficulties with access to healthcare that also play a significant role and can really influence their outcomes. Even if you're able to do a perfect job with the surgery, if they can't get to physical therapy for some reason, it's going to guarantee a worse outcome. So I think just trying to focus not just on the orthopedic problem, but on everything else that's going on in a patient's life is pretty important. I think my favorite part about being a doctor is the chance to kind of interact with people from various backgrounds and with various problems, and then you're given the chance to solve the problem and tailor it to each person's specific needs, whether that's a high school athlete who wants to get back to play in a few months so he can finish his season, or it's the older person who's been dealing with shoulder pain for many years and just wants to get back to kind of their normal day-to-day life activities. So when I was thinking about a place to work, there were a few things I was looking for. One was my wife and I both wanted to come back to the Midwest. She grew up here, I grew up in Michigan, and we kind of like the people and the atmosphere and the environment there. So I started to look at hospitals in the Ohio area, and from talking to a few people who were working here, I heard a lot of good things about Genesis. I was then able to come out here and meet a lot of the orthopedic providers who seem to do a great job taking care of patients and really have a focus not just on churning through patients or making money, but really a significant focus on patient care and doing the right thing for the patient. So when I was thinking, as a kid about a job or a career, I often did think about medicine quite a bit. My father is a practicing radiologist, so I was kind of exposed to that growing up as a kid. I have a mom who was a nurse as well, so I would say medicine kind of ran in the family. I went to medical school thinking I would actually be a radiologist like my dad, but then I did a few surgery rotations and really fell in love with orthopedic surgery, so kind of made that career switch to orthopedics, and that kind of medical trend still runs pretty strongly in our family. I have a sister who's a dietitian and then another sister who's a nurse practitioner. I think something unique about me is the fact that I was actually born and raised in New Zealand for about the first 8 years of my life. My dad then came to the US to do a few years of work training in radiology, and we ended up liking it so much that we've kind of stayed here. So now I have two parents in Ann Arbor, a sister in Virginia, and a sister in Seattle. So when I think about how I'd want to be taken care of as a patient, that's kind of what inspires my bedside manner. I like to take time to kind of clearly explain everything with a patient, whether that's going through their physical exam findings, following that up by pulling up the imaging in the room and explaining to them exactly what's going on with an MRI, showing them where their pathology is and what it should look like if it were normal, and then taking the time to explain, is this something we can treat surgically, or is non-operative treatment perhaps a better option? And then always taking the time to say, this is step 1, here's step 2, here's going to be step 3. If these things don't work, then we might consider surgery. But I like to try and give them as much information as I can, and also a clear guideline of how things will progress. So when I first encounter a patient in a room, there's kind of a couple things I like to make sure we cover during the visit. The first is just a thorough explanation of what their problem is, when it started, things that make it better, things that make it worse. I then like to spend some time talking about treatments they may have tried, whether it's physical therapy or injections. After I get a good sense of how the patient describes the problem, I think the next critical step is performing the physical exam, looking for both what I might expect the pathology is based on the history, as well as other things that are common problems. Once I take all that information, I like to review the imaging with the patient, now with the new knowledge from the exam and the history, kind of point out things I'm concerned about or findings that we should discuss. Then I like to sit down with the patient and kind of explain to them exactly what I'm thinking. Because you told me this was your story, you have this finding on your exam, I think it's most likely that you perhaps tore your ACL. And if you did, then we'll start to talk about, is this surgical options, non-surgical options, and the rest of the plan. I also like to find out a little bit just about the patient's other factors that are going on in their lives, whether that's they're an athlete and they need to get back to sport, they've got perhaps an elderly parent at home they need to care for and surgery isn't really possible because of the time off and the recovery needed, or if those other social factors should kind of influence the type of procedure we might be choosing. I think I've been lucky to come to work at Genesis. There's a lot of great providers here, and I'm hopeful I can add to that. I think I have a pretty strong background and very strong training, and I look forward to bringing that to this area. I think at Genesis, it's a very collaborative environment, and we're all working together to take the best care of patients. I think one of the most important things in medicine is not only learning what a patient's problem is, but also getting to know them as a person. So many issues in medicine arise not just in terms of a treatment or a plan, but you have to integrate that into the patient's entire experience. So whether that's they've just got a new job and they can't afford to take any time off work to recover from a surgery, we may have to look at other non-operative options. To other things is if they have to care for other family members or perhaps have young children at home, and sometimes surgical options may not be the best for them. So I think you can't just look at a problem on an MRI and treat it. I think you have to understand what else is going on in the patient's world. So I trained in sports medicine, and the kind of procedures I enjoy performing and can offer to patients here would be, in terms of shoulder procedures, we do shoulder arthroscopy, so that would be fixing torn labrums after perhaps a shoulder dislocation, a torn rotator cuff. We can also help treat pathology of the arthritis of the shoulder, so that involves shoulder replacement surgery, which could either be a reverse total shoulder if you have a bad rotator cuff, or an anatomic total shoulder where we keep the ball in the socket. I also enjoy operating on the knee. We do some smaller knee arthroscopy procedures, whether that's cleaning up a meniscus tear, or perhaps larger procedures like an ACL reconstruction or fixing other ligaments in the knee. When I look at the patients I've treated, there's always going to be many challenging patients and many people who have prolonged recovery, and maybe you don't get the results you're hoping for, but there's definitely a lot of successes with these complicated cases. I can distinctly remember one lady in her 70s who had a very bad knee arthritis. She had a total knee replacement, which unfortunately got infected. We spent a long time, many months, kind of treating her with antibiotics and some other surgeries to try and clear the infection. It took about a year of all these before we were able to put in a brand new knee, and maybe 6 months after that, she kind of got back to normal and then did well for many years afterwards. So I think it's stories like that where there's some persistence, you encounter some difficulties, but you're able to appropriately identify the difficulties and then work on treating them. And at the end of the day, although it's maybe a little bit longer than you would have hoped, the patient ends up doing very well. I think throughout my training, there's always advances in technology. It seems like every day there's the latest new gadget out there. A few things that have really, I think, helped me in terms of shoulder replacement is there's been more and more focus on creating computer programs that let us take the patient's images and create 3D models of them. From those 3D models, we can then practice, in a sense, the surgery and pick the implants and the components we'll need. So I can go into the operating room pretty much knowing exactly what I'll need, exactly what components I'll be able to put in, and I can also simulate how the shoulder will move on these programs, so I can be pretty sure I'm going to give the patient a great outcome.